Everybody is awake and the synapses are free from microglia. We come to the disease-specific presentations. In the interest of everybody, I like to remind the speakers that they should have 20 minutes and 5 minutes for discussion so we don't miss lunch. The first speaker had a little bit longer trip. It's Bart Neyns. He's from the Free University in Brussels. He's actually an old friend because he started, or he did a lot of glioma work, and at some point, I think he decided to switch a bit to melanoma, and after my talk later, you will understand why he prefers melanoma. Thank you for coming.
So, good morning, dear colleagues. First of all, of course, allow me to thank the organizers for inviting me to this meeting. I'm very honored. And Michael, be reassured, I've never really left the domain of glioblastoma. I'm still investing quite a lot in our own research. But as you mentioned, a lot of the excitement in the clinical breakthroughs went to the field of melanoma. And by chance, I was just having access to both worlds. So allow me for the next 20 minutes to quickly guide you through how this field within medicine as a first type of cancer showed us a way how we can effectively use our immune system to fight this deadly disease. And you're familiar with the fact that melanocytes derive from the neural crest and then populate the surfaces of the body. And at the level of the skin, they become the subject of the potential carcinogenic effect of UV light coming from the sun. And when these mutational hits harm the cells at specific genes, such as the BRAF oncogene, it can initiate the transformation of a normal melanocyte into a melanoma. And this is characterized by the accumulation of additional mutational hits. And we now know, we appreciate, as for all tumors in fact, that not a single tumor is exactly made up genetically as another one, but there are, of course, common themes. And within melanoma, especially activation of the MAPK pathway through mutation of BRAF, such as half of the melanomas carries this mutation at position V600. And in addition to that, mutations in NRAS are really drivers behind the malignant behavior of this disease. Yet another feature of melanoma, or at least most melanomas, not all, is that this damage by UV light causes a high, what we now call tumor mutational burden. And this is indicated here below. As I mentioned, not all, but the majority do come with a high tumor mutational burden. And this, in nature, defines that these tumor cells can differ from what's normal, because non-synonymous mutations alter the composition of proteins, and these then become epitopes, different from normal, that can be recognized by our immune system. And our current conceptual thinking is that the first thing that needs to happen is that these abnormal cells are picked up, recognized by cells part of our innate immunity. Actually, NK cells or eosinophils are probably needed together with tumor cells to create a gradient of attractive chemokines that then allow myeloid dendritic cells to enter the tumor microenvironment. And their physiological role is to take up antigens that are spread by normal tissues, but also by cancer cells, of course. And at the condition that there are sufficient danger-associated molecular patterns around, these cells will mature, and they will present these antigens within their MHC complexes at the surface. Maturation means that also co-stimulatory molecules, such as B7-1 and B7-2, are upregulated, and then T cells, cytolytic T cells, that recognize these MHC complexes containing these tumor-derived epitopes will get activated. When activation occurs, at the same time, these cells will also upregulate physiological breaks on their activation, such as PD-1 receptor and CTLA-4. Now, when finding, again, these MHC complexes now presented by the tumor cells, these cells will be triggered to try and kill off their targets. They do so by granzyme B and perforin secreted into the tumor cells, and interferon gamma is a key cytokine associated with this process. But a natural counter-regulatory mechanism then allows these target cells to upregulate PD-L1, and PD-L1-PD-1 interaction here withholds within the tumor the immune response from eradicating the tumor. Again, this is an oversimplification. Biology is still a lot more complex. You've heard about T-regulatory cells, partners in crime, normal cells that contribute to this immunophenotype of the T-cell inflamed microenvironment. But with this roadmap in mind, you can appreciate that our most successful therapeutic intervention today, immunotherapy, directs at the interaction here between PD-L1, PD-L1, disrupting this molecular interaction. Second to PD-L1, PD-1 is interaction with CTLA-4 at the surface of the T cell. And we also know that oncolytic viral therapies are active treatments, they are approved, but not everything we've tried here has been successful. And I'm pointing out, for instance, that the idea of using prophylactic or therapeutic vaccines has completely failed in the field of oncology, at the exception of prophylactic antiviral vaccines, of course. Now let me guide you through how, over the past 10 years, our treatment for melanoma has improved. Starting off like 10 years ago with chemotherapies that never could demonstrate to improve median overall survival, the first step forward was made using an antibody, ipilimumab, that blocked the CTLA-4 receptor at the surface of the T cell, not giving us a hand on a lot of responses. But when these trials matured, we appreciated that roughly 10%, 15% of melanoma patients derived an extremely durable benefit. The biggest step forward, in my opinion, was the availability of antibodies blocking the PD-1 receptor, and pembrolizumab, nivolumab took the lead in the field of melanoma, and they gave us a hand on higher response rates, up to 40%, better progression-free survival, and on top of that, durable overall survival at a lower cost of so-called immune-related adverse events. Adding 1 plus 1, so CTLA-4 plus PD-1, does provide a higher chance for response than PFS, but we're a bit disappointed, at least I am, that the small possible increment in overall survival should be balanced against excessive toxicity, and I'll come to that later. For half of our melanoma patients with a BRAF mutant melanoma, we can also use targeted agents blocking the BRAF and MEK molecules, and also they provide a very high rate of objective response, very nice progression-free survival, comparable to the best of our immunotherapies, but with a limitation in mind that we've never compared them head-to-head. We interpret the data today, cross-trial comparison, that perhaps long-term overall survival is a bit less. And I've already mentioned that also we have a registration for T-VEC, an oncolytic virus, but we're a bit puzzled where to position this treatment at this point, because clearly it's less effective. It only improves overall survival for patients with 4M1A disease. This summary slide again illustrated how much progress we've made. This is the very poor overall survival outcome of patients with stage 4 melanoma prior to having any of these immunotherapies or targeted therapies available. IPI, and these curves come from a pooled analysis over 4,000 patients, blocking CTLA-4 provides an incremental, long-term, durable benefit, now personally having patients going out for more than 12 years in complete remission, but to a small proportion of the population. Again, this big step forward came about by blocking PD-1. You can see here the curve for pre-treated patients in phase 1 trials, and then addressing the needs in first line gave us a hand on further improvement, and look how consistent these outcomes have been throughout different prospective large trials. Combining CTLA-4 and anti-PD-1, again, the incremental benefit in terms of overall survival is limited at the cost of higher toxicity. But Bear in mind that from a 1-year overall survival rate of less than 50%, we've now moved into 70% range, and this also is reflected by 3 years landmark survivals, here less than 20%, now moving up to almost 50%. And how does this compare to targeted therapy offered as a first-line option? Well, let's be honest, upfront protection may even be better with targeted therapies for BRAF mutant patients, but we tend to see here a crossing of the curves, and the interpretation, again with the limitations of doing cross-trial comparison, seems worse in the long term. Now, looking at progression-free survival of first-line anti-PD-1 therapies, realize that the majority of patients unfortunately still fail to do well on this therapy and will progress within the first 6 to 9 months. But beyond 6 months, what's characteristic is that the risk for progression becomes smaller, and the curve flattens out beyond 2 years. And I'm optimistic, bearing in mind, as I refer to IPI now securing some of my patients over 10 years, that again here we are seeing now the potential that roughly 25% of our stage 4 melanoma patients could be cured, offering them anti-PD-1 as a first-line option. And, sorry to go back for a while, exceptional also in one of those pivotal phase 3 trials, treatment was stopped here at 2 years of therapy. And you can see that one curve where patients were allowed to continue versus the one that stopped patients after 2 years, there is no drop-off. So reassuring that this can be curative without the need of continuing therapy. So conceptually, we're at a point where these T-cell inflamed tumors, those very well recognized already by the immune system, have a potential for cure. And we can achieve this by only blocking one molecular interaction. So for me, this is really PD-1, PD-L1, a handshake of the devil. It's a single molecular interaction that kills our patients because it can withhold the immune system, and magic can happen when you just offer one single molecule, anti-PD-1, like in this lady that I was actually in the beginning, we go back to 2014 when these medicines came available, reluctant to treat because she had failed previous therapies, was affected in the brain. But you can see that only with 6 weeks of therapy, pembrolizumab, and there is no miracle, there is no major difference in my opinion with nivolumab, but the body then can eradicate a large, high number of metastases, even in the brain. And after 9 months of treatment, she needed to stop because of toxicity, but she's out 5 years, doing well, keeping her complete remission. And again, this points out that also beyond patients we need to stop for toxicity, there are data, and I'll explain to a little bit further detail these two large set of data that indicate to us that in those patients who do well, we can stop therapy. We can't do this. We can't do this with targeted therapies, but we can with immunotherapies. And from the KEYNOTE-006 trial, we've learned that those patients free from toxicity and doing well on therapy, if they stop at 2 years, and then this is the new landmark here, then going out without therapy, actually they are at low risk for progression. And take note that the majority of this population only has a partial response on CT. But we can do a better job differentiating those partial responders who will do well from those at highest risk for progression by using PET-CT. And if the PET-CT is negative, this remnant lesion on CT has little predictive value in terms of progression-free survival. Now, how have we used these drugs in our daily clinics? And that's a question that my PhD student, Janina Jansen, set out to try and address it together in a collaborative effort with many colleagues across Europe and Australia. And she had a hand now on 874 individual patient files, and she found out that no less than 17% of patients, they electively discontinue pembrolizumab. And what's different from the prospective data I've showed you with the KEYNOTE-006 is that in these 185 patients who stopped treatment, the main driver was a complete remission, but treatment was stopped at a median of only 1 year. So half of what was done in Keynote-006. And there is no clear correlation with the best objective response, although there is certainly a trend towards a better outcome if the patients are in CR, but there is no, at the exception of less than 6 months of therapy, a clear signal how long we should treat. Now with survivorship also comes responsibility of taking care of specific needs of these survivors. And we've come across a number of patients that really struggled with their survivorship in terms of psychosocial issues. And we are effectively addressing these needs now prospectively in our patients. What we've also elegantly done in the field of melanoma is bridging the need of helping out patients who are in an adjuvant situation. And we are lucky to have 4 randomized trials being positive, addressing the needs up from where patients are affected with a 1 millimeter metastasis in the sentinel node. And the hazard ratios of these trials comparing targeted therapy, but pembro and nivo against placebo, indicate that we can roughly halve the risk, limit the risk to half of what it is without effective therapies. The moving edge here, and very exciting news, comes from neoadjuvant treatment, where across a number of phase 2 trials, high rates of pathological complete responses have been observed, and very intriguing even in studies such as this one led by our Dutch colleagues from the NKI at Amsterdam. We can see that for immunotherapy, those patients deriving a pathological complete response from their therapy seem to do extremely well. And that gives us a hand for the future, perhaps to use this approach to tailor the needs, also duration of therapy, elegantly to individual patients. But of course, there is still a lot of work to do. 70% of our patients still fail on therapy, and we like to think nowadays of these tumors being either T-cell excluded phenotypes or immune deserts. And a lot of how to make progress has been dominated by the idea that the first thing to do is actually to allow the immune response to move into the tumor, and then eventually, probably still being in need of resolving the issue of PD-1-PL1 interaction. And a lot of those combinations are now clinically explored. I'll quickly, because I'm running a bit out of time, I'll quickly guide you through some highlights. And the one that's definitely most often used and available as a standard of care is combining CTLA-4 and PD-L1 inhibition, PD-1 inhibition. And our data, our insight on how much value there is for upfront combination come from this 3-arm trial. And a bit disappointing here is that the activity is not additive. We have a higher response rate, but it's not even additive, if you like. And we see an early split of the progression-free survival curves. But let's admit that despite the significance and the difference that is maintained numerically, it's small. And I personally am disappointed that upfront combination does not provide at all a better outcome during the first year of survival. And the small difference we are seeing here, be it with descriptive statistics, cannot be called significant. And then why bother? Well, the reason is that we do see a synergy at the level of toxicity. And upfront combination definitely exposes patients to a higher risk of severe toxicities, while, as mentioned, with a lower toxicity, also a reasonable proportion of the population can be elegantly managed with durable good outcome. There is one exception to my opinion that not all patients are candidates for upfront combination. That are patients with synchronous brain metastasis, where indeed it's phase 2 evidence, the outcome looks very good for this subpopulation. But bear in mind that those ones with symptomatic disease derive far less benefit, and this is definitely still a very challenging population, so melanoma patients coming in immediately with symptomatic brain mets. And perhaps those needs can be better addressed when we combine the two most effective treatment options, at least for patients with BRAF mutations. And who would have imagined that we would see this kind of waterfall plots in stage 4 melanoma? These come from phase 1 trials that have demonstrated now that triplet combinations of BRAF MEK plus PD-1 are tolerable and give us a hand on excellent activity. Yet again, a cautious note here. The first data set presented at last year's ESMO meeting indicated that when we are looking here at progression-free survival and overall survival in a randomized phase 2 comparing BRAF MEK, dabrafenib, trametinib with a triplet, to be honest, I'm a bit disappointed here, and we will definitely need to wait and see the results of ongoing 2 large randomized phase 3 trials. A lot of excitement again with approaching additional checkpoints, but at this point in time, perhaps not at the level at what we would have hoped. Most of these additional checkpoints, when blocked as single agents, are not very active, yet they are taken forward in combinations with anti-PD-1 or PD-L1. But let's not forget that first-in-kind molecule that by itself had no activity, and I'm alluding to epacadostat, an inhibitor of IDO1, despite some enthusiasm about phase 2 data, completely failed to improve PFS or OS in a randomized phase 3. So those are really sobering results. And don't punish your eyes to see this difference. These are 2 curves, but they are completely overlapping. Finally, perhaps, and I admit being a bit biased because it's a subject of our own research, the use of intralesional therapy, and the lead here is with TVEC, an oncolytic herpes-derived virus. Very interesting data coming from phase 1 experiences. And as mentioned, we have also moved in using this intralesional therapy together with myeloid dendritic cell therapy to try and address the need of those who fail to respond to checkpoint inhibition. And my enthusiasm comes from our first observations that yes, there are still possibilities to address the need, such as this elderly lady having failed anti-CTLA-4 and anti-PD-1, still responding to this type of immunotherapy with a complete pathological response. And these intralesional therapies definitely also give us a hand on a readout, because we are going into the tumor, we can take out the material and try to understand what is this extra possibility, how does it work, how can we offer effective immunotherapy, develop it for patients who fail our current standard of care. So with this I would like to end, and I hope that I've illustrated to you that while 10 years ago taking care for melanoma was really depressant activity, and perhaps still so for glioblastoma, but let's hope that it will change in the same way. Maybe we can bridge that knowledge from melanoma to glioblastoma. But nowadays, luckily, it's not only those sad letters. I also get patients who do really well, can live their dreams, travel far, enjoy life. And the most rewarding kind of posts I get definitely are these ones. They come from young patients affected by stage 4 melanoma that go all the way, start a family, and even get children. But the job isn't over. Like this young gentleman who became father of a twin, after 2 years of remission, had a relapse, and he's in treatment again, and we should definitely not stop looking for better possibilities to tackle the problems of all our patients. Thank you for your attention.